morning and welcome to Doctors on Call. I'm Dr. Peter Nalin, Professor and Department Head of Family Medicine and Biobehavioral Health, Associate Dean for Rural Medicine and co-leader of the Duluth campus of the University of Minnesota Medical School. I am your host for our program tonight on lower extremity, knee, foot, and hip problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Joshua Rother, an orthopedic surgeon with Orthopaedic Assoc of Duluth, and Dr. William Uffmann, an orthopedic surgeon with Essentia Health. Our medical students answering the phones tonight are Katie Benson from Staples, Minnesota, Claire Buntrock of Rochester, Minnesota, and Megan Saratori from Bemidji, Minnesota. And now on to tonight's program on lower extremity, knee, foot, and hip problems. The first question, Dr. Rother, why is osteoarthritis called wear and tear arthritis?
Osteoarthritis is called the wear and tear arthritis because it's simply a loss of cartilage on both sides of the joint. There's a clear genetic basis to the development of that. There's a difference from patient to patient in terms of the severity of that. Treatment in terms of management of that can be lots of conservative, non-operative when it gets to the end stage of arthritis where it's bone on bone. Certainly looking at things like joint reconstruction are a useful tool to get patients back to good quality life and living.
Thank you. Dr. Uffmann, for you the question is, what new technologies are improving hip replacement surgeries?
Sure, that's a great question. So I think things that we've been learning since they started doing hip replacements in the 60s is improving the biomechanical properties of the materials that we actually implant in people, the way that they're fixated into the bones. Instead of using cement, we now use in-growth prosthesis where it's special metal that our body can actually grow into. Also in terms of the polyethylene plastic liners and the approaches that we use improve the way that patients recuperate. We think that it helps them improve even more quickly.
Wonderful and very interesting. What would one expect to experience if a patient needed hip replacement surgery? WDSE's Jason Sebo shares more on his decision to have surgery in this clip recorded earlier this week.
I think when it finally came time to finally make the decision to have my hip replaced was when it became unbearable. I saw doctors, I saw the x-rays, and if you look at the x-rays, there's supposed to be a gap between major bone groups, and that's the cushion that allows you to function. Well, that was gone, and it had progressed into other areas. My gait was different. I had a bit of a limp all the time. Well, what that does is it messes with other systems. And I finally got to the point where I just couldn't take it anymore. It was a decision that, talking with my wife, you've got to do this now. Most people have to go through pre-surgery prep. They have to exercise the muscle groups in order to get them strong enough so when you are recovering, those muscle groups don't atrophy or they're able to come back faster. As far as prep work, relatively easy. You go into the hospital, you go through the normal procedures, you get a shave, because that happens. You have your IVs and you're dressed and you're wheeled into the operating room. I specifically had a spinal block. After that, within a week, I was not using a walker and not using a cane. That's how fast I came back from this, and that was just on the left side. I was in a lot of pain for a long time. This wasn't something that was just happened on a whim because of an injury. This was 10, 15 years worth of pain and hobbling and not feeling like myself and just being held prisoner by my joints. After the fact, much happier. pain is so far less. And what I mean by that is there are twinges. Like I said, when it gets cold outside, it hurts. But comparatively speaking, night and day. And I'm a much happier camper. My wife will attest to this. My kids will attest to this. I'm not a patient person, but you've got to be patient, and that helps you and motivates you to continue with your PT, to continue using caution, but also to start living again. And that's, for me, that was the biggest thing, is I wanted to get back to my active lifestyle when before I didn't have one.
We're fortunate to hear this firsthand account from a patient. Dr. Uffmann, how does this story compare to what you hear?
Well, I think it rings really true with what I experienced in my own practice, that I wish that all the surgeries that I do have as good of outcomes as the total hip replacement. I tell my patients I think that's the best surgery that we can do for patients. 98% satisfaction rate. People are up and walking the same day. All that pain, like Jason said, all that pain that he had is completely gone as soon as he wakes up from the surgery, and that's really powerful to be able to give that to people.
Wonderful. Dr. Rother, how do orthopedic surgeons participate in preventing wrong side surgeries?
I think that's a great question. It's something that can be an issue, and there's accepted standards at every hospital that's very universal. We mark the site in the patient's presence before we bring them back to the operative suite. When we are in the operative suite, we also do a timeout where the circulating nurse reads off the consent, verified by anesthesia, as well as a circulating tech, in addition to myself, to confirm that, because a lot of what we deal with is laterality, and it's very important to get this right, and hospitals have very established protocols to prevent this important issue.
It's very reassuring and an important protocol. Dr. Uffmann, let's traverse further down the lower extremity. This question is, what is the recovery time for an Achilles tendon repair, and why?
So I would say that, you can almost apply a principle on any orthopedic injury, that there is sort of you're looking at a year of total recovery. And I think about it as sort of, if you're a mathematical person, that you can almost apply it to like a logarithmic graph, where you have pretty rapid progress that sort of slows down over time, where the very high slope area is kind of the first 6 weeks to 3 months. All injuries or surgeries, we try to protect people for 6 weeks to sort of foster the real strong healing, encourage range of motion over the next 6 weeks, so that by about 3 months, we as orthopedic surgeons feel more comfortable with actually letting you start to strengthen, return to activities sometime in the 4 to 6 month ballpark, kind of based on what your demands that you're going to place on that, I guess in this case, your Achilles tendon.
Thank you for that. Dr. Rother, how does range of motion impact your clinical advice about knee replacements?
Well, range of motion is a very important thing that patients want to achieve post-surgery. Oftentimes what they start out preoperatively before knee replacement, we can gain 15 to 20 degrees on. It does give us a little reflection of things that we may have to do intraoperative to account for those deficiencies, contractures, by different bony resections to help balance out that knee so they have a stable platform that has improved range of motion, better function, and certainly less pain. So it's an important factor we look at in the pre-op assessment that's going to ultimately kind of determine the course and how hard they're going to have to work on their therapy afterwards.
Dr. Uffmann, a patient asks, could you say a bit about Morton's neuroma and metatarsalgia and some of the treatment or diagnosis of it?
Sure. So Morton's neuroma or metatarsalgia are kind of pain in the forefoot. A Morton's neuroma is typically in between your second and third bones of the foot. And basically it's typically symptomatic when people walk. There can be some radiating or shooting pain from kind of the forefoot area into your toes. Metatarsalgia being kind of very similar, maybe the characteristic of the pain is slightly different. And typically the treatment is kind of the same. It's getting good inserts for your shoes, having shoes that fit you well. If you can't find shoes that fit you well, going to some place that can perhaps make you custom inserts or get you the right kind of shoes. If that doesn't get you where you need to be, then you step it up with anti-inflammatories, potentially local injections. Sometimes, stretching, and probably the last resort would be, resection of the neuroma, or potentially, if it's metatarsalgia and there's some way that your foot is acting like a platform, correcting bone angles, shapes, so that you don't put as much weight through that area of your foot.
And Dr. Rother, also a condition of the feet. What are some of the findings that might indicate peripheral neuropathy?
Well, the most common findings can be numbness and tingling. There's going to be a lot of different reasons for that, certainly diabetes being one of the prevailing reasons for that to develop. Occasionally you can get that if you had a compressive neuropathy in the back, but numbness and tingling would be the predominant finding. You could see some weakness on exam as well, and the treatment's going to be aimed at the true etiology of that. In some scenarios you don't know exactly what the cause is, but most commonly diabetes is going to be one of the top ones on the list, and good diabetic control being important to manage that.
And Dr. Uffmann, also about the feet, what is plantar fasciitis and why might it hurt more in the morning?
Sure. So plantar fasciitis, so the plantar's fascia is sort of like a windlass mechanism. If you're a sailor, it basically kind of helps to sheet in a sail. In this case, the plantar fascia attaches from your heel bone and runs out to the very ends of your metatarsal bones, and it almost creates a stable arch for the bones of your feet. So it's under constant stress during weight bearing, and it just happens to either bother you at one end or the other. It's more common that it happens at the heel end. And so typically, it's like anything, it's going to be more painful in the morning because when we sleep, our feet go into sort of a toes down position, and then when you go and stand up, you stretch and put that fascia on stretch, and that can be quite painful. So good treatments for that are sleeping with special socks that will actually stretch your feet at night, and then just doing stretch exercises in the morning, and it has a very good, successful outcome without surgery.
And Dr. Rother, this question is about knee surgery. Why might a patient be advised to get their BMI under 40 before undergoing knee surgery?
I think that's a great question. It's certainly a hot topic too as well. We look at a lot of risk factors perioperatively, and the whole drive at this moment to get BMIs less than 40, optimize other conditions like diabetes and anemia, stop smoking and things of that nature, is just to improve outcomes. Quite honestly, with joint reconstruction, it's been clear and proven that the complication rate with respect to infections is significantly lower when we have these other modifiable risk factors under control, BMI being one of those big ones on that list in terms of wound healing. And it's an important topic that both St. Luke's, Essentia, and all the other major hospitals up here look at perioperatively to ensure that we're going to have a good outcome on what is generally a very successful procedure.
To aim for those best outcomes.
Absolutely.
For the patient optimization. Thank you.
It.
Dr. Uffmann, a new question. How would you evaluate a patient with pain behind the kneecap?
Sure. So pain behind the kneecap, I guess you think about, what is the patient doing? When does it hurt? Typically pain behind the kneecap, at least in my experience, comes about when people are going up and down stairs, going down steep hills, hiking, that kind of stuff. Obviously want to get some x-rays, and potentially based on their age or what the x-rays show, an MRI to kind of see what is going on, what their cartilage looks like. Is this more of an arthritis kind of a picture, or is this more of a focal cartilage lesion that could maybe be treated with some kind of arthroscopic procedure? Talk about injections, talk about potentially physical therapy if you can find some correctable muscular imbalance or flexibility imbalance that you can correct to try to take the stress off of the kneecap, because the kneecap sees about anywhere from 6 to 12 times our body weight with activities of daily living. It's the thickest cartilage, but also has the most shear of any part of our body. So it really takes a bad beating. So anything that we can do to kind of make its mechanical environment more healthy for it is going to do good for your knee.
Dr. Rother, also in the vicinity of the knee, what is Osgood-Schlatter disease and why does it arise in athletes?
Good question. It's a very common condition we see in adolescence. It's where the growth plates open, where the patellar tendon inserts. In athletes, as they're doing running and exertion, it can cause a lot of traction and strain on that insertional point with that open growth plate. It can be very painful. It's generally well managed with conservative treatment, including anti-inflammatory stretching. Sometimes use patellar tendon straps or braces to protect against that. It is a very common entity, unfortunately, and the pretty much vast majority of the cases this will resolve with time, and rarely, if ever, is surgery recommended or necessary for that. It's generally just a conservative management, and you can push through on the play, but yeah, very common condition we see and treat all the time.
Dr. Uffmann, also in the vicinity of the knee, what are shin splints and their potential treatments?
Sure. So shin splints is kind of a spectrum of things, and it's typically an overuse injury. It occurs in the tibia, which is obviously your shin or your leg bone. It's the main weight-bearing bone of your lower limb, and it's typically seen in people who are trying to do something too much too soon. So we see it a lot in young people that go out for cross country or start playing sports and they're not very well conditioned and they're running or doing too much weight-bearing activity, or military recruits. It's a very common thing. And it's basically just the bone is not strong enough to react to the stress that it's being applied. So typical treatments are rest, relative rest. Sometimes it can be as strict as non-weight-bearing, but it's typically very well managed with modifying your activity. And then in some cases it's metabolic, so trying to get people to eat better, be more healthy, take vitamin D, that kind of stuff.
Dr. Rother, what are a few common reasons for recommending or needing a knee brace?
Yeah, knee bracing we use for a whole host of entities. In one respect, for arthritis, we can use unloader braces to take some strain off that compartment that is showing signs of wear, especially in the earlier stages. I will say that patients' compliance is maybe not the best for that, but when they are compliant, I do think it's effective. We oftentimes will use bracing post, like say ACL surgery, to help support that ligament that's been reconstructed, just to ensure that's not going to take undue stress. And another real common reason for bracing would be for kneecap-related issues, like we had talked about before. When you're having some kneecap instability, those braces can help to support that kneecap mechanics and keep things in alignment as they're going through the recovery and rehab and re-strengthen the knee to help improve those patellofemoral dynamics.
Dr. Uffmann, what makes avascular necrosis a serious condition?
Sure, it's basically avascular necrosis is sort of a disorder of your bone that usually kind of in end stage leads you to a knee replacement or a hip replacement, depending on where you have it. So I think it's serious in that regard, in that the sort of downstream effect of it can lead to your bone collapsing, which there really is nothing other to do at that point than to replace your hip, or a knee in this case. So in that regard, those procedures, while good, do have some serious consequences, but it does kind of handcuff a surgeon in terms of how they can help you.
Thank you. Dr. Rother, a patient had a total knee replacement recently and now has Baker's cysts. What might be done about Baker's cysts?
Well, it's a great question, and Baker's cysts are a very common entity. Typically, as the knee is arthritic, you're building up a lot of fluid pressure, and in some scenarios that can escape out into the back of the knee and form a cyst or a pocket there. Generally, the remedy is going to be doing exactly what she had done with the knee replacement, and in time it's fully expected that that cyst will resolve. In some unusual scenarios, we will remove that if it persists, but in most scenarios, if you address the issue within the knee joint, that cyst will run its course and dry up, and the symptoms will improve after that's all said and done.
Good to know and encouraging. Dr. Uffmann, what can be done for treating bone spurs in the ankle or foot?
So I think it probably depends, one, on the location, and two, whether or not they're symptomatic. So, heel spurs, so spurs on the heel can be difficult or painful with shoe wear. They can be removed if you can't find shoes that are comfortable. If you have bone spurs in your ankle and they potentially cause decreased range of motion, those can sometimes be removed either in an open surgical fashion or sometimes in an arthroscopic camera-driven fashion. So I guess it all kind of, like everything in orthopedics, it boils down to what's your real complaint? Is it pain? Is it range of motion? Is it weakness? Or, because sometimes you have bone spurs and they don't bother you. And so we try not to, it's the do no harm. If it doesn't harm you, then, we try to let it be.
Thank you. And Dr. Rother, what can patients expect about infection control and prevention? A few examples if they're anticipating surgery ahead.
Yeah, that's an important topic. For us, infection control starts with some of these perioperative factors for patients too. So if they are diabetic, good diabetic control is important. Things we do personally in the operating room include, giving antibiotics beforehand, sterile technique, being really cognizant on those important factors. But I think it's kind of a combination of effect with what we do perioperative with good nutrition, good diabetic control, and then the other measures that we take intraoperative. And because an infection is a very serious consequence of some of the surgeries that we potentially do, and it's not as if it's a zero risk, it is a risk. And once it happens, it's a matter of how we address that and take care of that issue to get them back on track.
Thank you. And Dr. Uffmann, a patient reports tendinitis and tenosynovitis, brachymetatarsia. What are some approaches to a patient with those symptoms and conditions?
I feel like you have to speak Greek fluently on this show in order to be able to understand what we're talking about here, but so tendinitis, tenosynovitis, brachymetatarsia. So those are all sort of conditions of the feet. Inflamed tendons, inflamed tendon sheaths, and of course short metatarsal bones, which all would basically kind of affect, pain when you put your foot down or pain when you move your toes. And so it kind of comes back to the same orthopedic principles of rest, ice, activity modification. If we do feel that we can't calm down your tendons or your tendon sheaths with those sorts of things, sometimes there are tendon diverting surgeries or bone lengthening procedures that can be considered. But most of the time, foot conditions can kind of be treated non-operatively.
Dr. Rother, you mentioned the patient's participation in their recovery. Anything about casting materials or the care of casting that patients can be helpful and positive about?
Yeah, when we have to apply casts, which isn't infrequent, it's important that they take care of the skin around, they control swelling. If they're having itchiness, using antihistamines to help with that rather than scratching that skin surface, because I've seen scenarios where they've gotten infections from that, but it's important to take good control and care of the cast. Oftentimes we have to change casts out during the process of fracture management, and that's not an uncommon thing. As the swelling does go down, the cast can become a little more loose, and there can be issues with how it's holding that fracture in position or causing skin-related issues. So cast care is important. It's a hassle, but generally it's a short-lived hassle in most scenarios, and it's something that we certainly watch seriously.
Mm-hmm. Dr. Uffmann, a swimmer is experiencing swelling right below the knees that then goes away. What might be contributing?
That is a difficult question to answer, I would say. I guess depending right below the knee, that would almost be something they'd have to come in and sort of be looked at. I guess you could think, is that some sort of patellar tendinitis or inflammation? I guess particularly if they're doing a lot of kicking. That'd probably be my best guess.
Yeah, I agree with you. I think a good clinical exam and see their pressure points are, and from there determine. But I agree. I think it's probably more patellar tendinitis, I would suspect, if it's right below the knee.
So a good clinical exam would be a good next step.
That'd be the best way to determine that.
The best thing for all orthopedic conditions is a good clinical exam.
Right.
Yes. And a patient is experiencing numbness of the entire leg at times. Any other thoughts beyond certainly a good physical exam?
Yeah, I think it's getting to the source of what may be causing it. There could be a multitude of reasons for that. I would say if it's the entire leg, the most common thing that would come in my mind would be a compressive neuropathy in the back, whether it's from bone spur formation there or a disc herniation. There could be peripheral entrapment, but if it's the entire leg, I would think it more would line back into the back. So a good history will help. Exam's going to help, and probably some diagnostic studies to follow if the exam supported the initial thoughts and ideas about what was causing it.
Well, I'd like to thank our panelists, Dr. Joshua Rother and Dr. William Uffmann, and our medical student volunteers, Katie Benson, Claire Buntrock, and Megan Saratori. Please join Dr. Ray Christensen next week for a program on men's health and kidney stones, when his panelists will be Dr. E. Tolga Hanhan and Dr. Benjamin Marsh. Thank you for watching. Good night.
Kind of standard stuff. Don't gotta soak it, just gotta clean it.